Okay, good morning to or good afternoon to our faculty and doctors.
Sarebbe una
Good
gran
evening
cosa
to
sentire l'audio.
my doctors in China. Hi, Codovona. It's good morning for you and good afternoon to European doctors and good evening to Chinese doctors. You know, it's our way together. Since the introduction of the Domino Effect project, it became very popular in Europe. The protocol has allowed many doctors to witness the amazing result of Domino Effect proposed by Filmed. Really thanks to Filmed to organize this event. We have invited very experienced KOLs to conduct injection and anatomical demonstration for us. They are Dr. Carlo, a very famous facial plastic surgeon from Italy. Dr. Carlo, hi.
Can we turn on the ventilation?
He will perform Domino protocol with deeper piriform facet injection. Our old friend, the very famous Professor Cotofona from United States, he will speak about Domino anatomy and fashion by mechanicals. Hi, Cotofona, nice to meet you. And the well-known Professor Anicio from Italian. He's the one of the founder of original Domino Effect protocol and will present an injection demonstration with his outstanding technical. Thank you, Anicio. Thank you. And Professor Xia Wei, she is a famous plastic surgeon from China. She will present his experience applying Domino among Chinese patients. Welcome, all of you. Welcome. I'm Dr. Luo, and I will join you today as the chair. Please be sharing the slides. Okay, this is the agenda of today, and we will begin with my opening and end with Q&A. The entire event will last for 2 hours. Next slide. First, I will do some introduction of this concept. Next slide. Okay. Next slide. According to the result of a survey among over 8,000 women from 18 to 17 years old, 15% from 14 to 49 years old women start saying they are concerning with facial sagging. The date gradually increased with age and up with 37% from 16 to 75 years old. But only 10 of the women are interested in aesthetic medicine with conduct for sucking, which means patients are asking for lifted face and V-shape of the face. Concerning issues such as overfilling, they don't want too much volume in the middle face. At the same time, some adjustments need to be made for Asian patients. Next slide, please. And the facial aging is a complex process. Understanding anatomy of every organ is very important to guide direct facial treatment since everything is connected. Treatment at home can have a positive impact on neighboring areas. This is the fundamental of Domino Effect. It's a really great idea. Next slide. Next slide, please. The goal of Domino Effect is to, very simple, restore the V-shape, define the gravity, recreate the natural young face. Of course, I will be helped with it will be help with perfect product and adapted to meet different patients' needs. Next slide. Just like the slogan of Filament, we start with amazing articles to make the beauty into size. Minimum investive lifting technique starting with the tempo. Next slide. And this article told us inject literally we allow to minimize the quantity injection medially. Next slide. Really thanks to Professor Cotton for now. We notice the line of ligament. It's really well known. Every doctor in my country knows line of ligament, which is pass through temporal adhesion, lateral orbital thickening, zygomatic ligament, mesenteric ligament, and mandibular ligaments. Next slide, please. To the lateral of the line is mainly smooth, everyone knows that, which means only a few expression muscle fiber here, and the mobility is relatively high. Injection in this area can make a lifting effect to the face. However, the median of the line is facial muscle and the superficial fat pad, which causes an active mobility. It means this tool is not a right tool to lift the face, and we can only give them a little bit of projection. That's all. Next slide. Thanks to the unique tri-high technique of filament, Artifila have become a perfect injection product with longest chains and marked, optimized incorporation and optimized concentration. Next slide. The volume is a high G-ply, is suitable for temple area, middle face, and jawline. Next slide. While the universal with medium G-ply, which is proved can stimulate collagen regeneration, and it is a perfect filler for nasolabial fold and melanotia lines. Next slide. Combined with the perfect anatomy idea and the perfect product, the Domino injection strategy is invented by injection start from the temple to middle face and finally to mandibular angle or jaw. Next slide. To adapt to different patients' needs, Domino in fact creates different injection methods, named as Domino, with focus on temporal lifting, Domino protocol with focus on piriform fossa, and the Domino adapted to Asian profiles. Next slide. The patient's safety always came to the first. That's right. We have to respect the basic of anatomy and facial biomechanics. This is why we hold today's event. Next slide. First, let's welcome Professor Cotofona to make a speech about facial anatomy and biomechanics. Thank you. Next slide.
Professor Lu, thank you very much. It was a great pleasure hearing you speak because you referenced the most important scientific papers when it comes to understanding the domino effect and when it comes to understanding facial biomechanics. And I think this is also a hallmark of the upcoming webinar, because what we're going to focus on is on safety first, and of course on evidence-based medicine. And all of this you will see combined within the patient treatments. And Professor Lu already made a very important point about a topic that is called facial biomechanics. And this topic is important because it describes the face during facial expression, so that means during mobility, but also this mobility happens during the process of facial aging. So there are two types of movements that happen in a face. During facial expression, which we want to preserve because they should be and maintained natural, and during the process of aging. So these two things, facial expression and aging, these are important and they comprise facial biomechanics. But for this, we need to understand a little bit what is facial biomechanics and what has to do with this game that children play that is called Domino, right? How are these things acting together? And this is why I would like to start to present to you someone that you actually know, and that's actually Max. You know Max very well from previous transmissions. And it's important to note that what happens to Max is the fact that Max, you can imagine Max like a square. You have a front part and a side part. You can see those aspects. And when you look from the lateral aspect, there's a diagonal. And this diagonal is where you have the skin surface projection of the four most important ligaments of the face. One on the temple, then one on the orbit, zygomatic arch, and on the mandible. And they comprise the line of ligaments. And this line of ligaments separates the lateral from the medial face. In addition to this, we also know that in the medial face, we have a substantial amount of mobility, which we do not have in the lateral aspect. In lateral aspect, we have a lot of stable components, which then also co-influence what happens medial. So important to note, the face, like a square, diagonal, there is where is the line of ligaments. But actually, this is only one-sided view on the skull, but what if we look into a pre-dissected donor? And guess what? I prepared one for you here. Now, if we switch the camera to the top view, I can present to you the donor that I prepared previously for you. And again, on the donor, I would like to showcase to you the respective aspect that you can figure here. This here is the zygomatic arch, as you can see here. Here we have the orbital rim, and here we have the temporal crest. These are the factors that you can palpate. And if you move downwards, you can also find the mandible here. Now, when you look at the skull, you can see an anterior aspect and a side aspect. And exactly at the diagonal area here, there you have the line of ligaments. And now we need to go a little bit deeper. For this, we will reflect the skin, as I will do right now here for you, because this is the entire flap that I reflected. And as we reflect the skin flap, we can expose the more superficial fatty layer. Now, here what you can see is a continuous superficial fatty layer, and this superficial fatty layer during the process of aging moves downwards. It follows the effects of gravity. So in the past, when we were thinking about the regular shape, the V shape, it means that here it's more narrow and here it's a little bit wider. But during the process of aging, with the descent of the soft tissues following the effects of gravity, the volume from here moves downwards here, and with the volume having down here, this increases the volume here. And this is why there is a transition from a V shape, as you can see between my fingers, from a V shape to a more triangular shape with more volume being in the lower face. But here's the important aspect to understand. It's not that we have suddenly volume increase. It's just the displacement of a volume. It's the soft tissue descent from more superficial layers moving downwards. And it's important to know that exactly what happens here can be restored by applying the aesthetic principles. The aesthetic principles, we have 3 of them, and they are called upper face first, lateral face first, and deep regions first. So these are the aesthetic principles. And what do they mean? They mean we start the treatment first in the upper face or in the region above. That means with the temple. And then when we move on with the treatment, we always stay lateral to the line of ligaments. And this here you can see, this is the skin surface projection of the line of ligaments, because this is the skin, and deep to this is where we have the line of ligaments, and that means we stay in the lateral aspect. So this is lateral face first. And then the third principle is deep regions first. To do so, we need to go, of course, deeper. And guess what? I prepared that dissection as well for you. And here you can see that there is a continuous layer going from the temple all the way down into the lower face. You can see here the temple, and in a superficial temporal fascia, you can see how the superficial temporal artery is included. And here downwards, here you can see the platysma muscle fibers. And if we switch back to the top camera, you can see that this is a continuous plane. And this continuous plane can glide from more superficial regions downwards. So in other words, when we are young, the planes are located like this. And when we're advancing in age, the planes move downwards, as you can see here. And this can be restored by treatments of lateral and upper face and deep regions first. So now if we move to the side view, you can see that I had to transect the superficial temporal artery because it was attached here, so I had to transect that respective vessel. And as I'm reflecting now the layers, I want to walk you through the respective ligaments that Professor Liu already mentioned. For instance, here in the upper face, here you can see this area here, we have the temporal ligamentous adhesion. It is located here. If we move further downwards towards the orbit, we have the next one, which is called the lateral orbital thickening, is located here. That's this area here. If we move further downwards and in close proximity to the bony origin of zygomaticus major muscle, which we can see here, we have the zygomatic ligament. And then if we move further downwards, we leave the masseter muscle and we move downwards towards the mandible, where we have here the mandibular ligament. So we have mandibular ligament, zygomatic ligament, lateral orbital thickening, and the temporal ligamentous adhesion. And if we then elevate the entire flap, you can see how the entire flap is moving, but it remains attached to the respective ligaments. And this is what we refer to as the line of ligaments. And now, if we summarize this, I hope you can understand what it means, the domino effect. The domino effect means that if you treat one facial region, like the temple, it will have an effect on the next region, on an adjacent region. So if we treat the temple, we have an effect on the midface. Why? Well, because as you can see here, they are connected. And also if we treat the midface, then we have an effect on the lower face. Why? Well, because they are connected. And this is what is referring to the domino effect. We're treating one area, we have an effect of an adjacent area, and we co-influence other regions, as you can see here. And now I'm reflecting back the skin into its original position. And as you can see here now, these are the understandings of facial biomechanics, of the aesthetic principles, and of the layers of the face. All of them you can combine into a treatment concept. And if you apply that respective treatment concept, well, then you reach to the conclusion that one region co-influences the other. And that is, in other words, the domino effect. So this is the major topic of today's webinar, and I hope I was able to explain to you the facial biomechanics, how they interact with each other. And now in the following, we're going to see live treatments. But before that, we're going back to Professor Liu.
Oh, thank you for your great demonstration, very, very clearly. Thank you very much again, Kutfuna, and I hope to see you soon in China. With the understanding of anatomy, I believe we can start our live demonstration now. First, I would like to invite Professor Anisil to show his technique of domino protocol with focus on tempo lifting. Dr. Anisil is the founder of the domino concept. He is really very, very active and very, very outstanding for me for this lovely concept. Dr. Anisil, please. Thank you.
Hello. Thank you for the wonderful presentation, and welcome all the colleagues from all over the world. I know that a lot of colleagues are connected. I welcome, and I am very happy to be here in my Milan, in University of Humanitas, and I have a wonderful patient that is particularly indicated for this domino philosophy, domino strategy. You see that my patient is following the slide that you see here. I will start with the temples, so bolus laterally and then temples. Then I will inject the temporal area, and then finally we will see what is the result. We will inject also this part and this part. In my opinion, it will be needed, and also maybe a light injection also in nasolabial folds. Here you see the patient, you see the diameters, the zygomatic, bitemporal, and bijugal diameter, and you see what Sebastian told you in a so good way, and I now translate for you in clinical anatomy. So, zygomatic, the temporal crest, this is the first entry point, here nearby the tragus to go up in the air. Then the second entry point on the zygomatic arch. And then here, I prefer from here to improve the mandibular part. Here you see the main arteries, again translated, you saw so beautifully, but I have a live patient, and so the temporal artery that at this level becomes more superficial and divides in frontal superficial temporal artery and parietal. This creates a light epsilon, and we have to inject the bolus here. Some complications, very few are described for the alopecia, but if you inject in the subcutaneous tissue, not too superficial to create a ischemia of the air bulbs, is really very rare, much rarer than what happens on medical rhinoplasty. So while I continue here, I have my, thank you, you give me the entry point, the needle. I do the first entry point here to do the bolus. I use art filler. The domino technique is so important because it's done with only a high G' filler, and in this case, art filler volume. It is done and stated by this filler because it has a particular rheology. If you do with another filler, everything changes. So I strongly suggest you to use the right filler. That is, in this case, I use only the art filler volume. I do the entry point here in front of the tragus. Perfect, thank you so much. Wonderful. And I use a cannula 22 gauge per 50, and you have to enter in the subcutaneous tissue, and you must remain in the subcutaneous tissue, really in the subcutaneous tissue. If I elevate here, I feel my cannula where and I do an aspiration test twice longer than with the needle because the cannula is a little bit longer, so I wait a few seconds, and then I do my injection in the air in between the temporal frontal artery and here the parietal frontal artery. I feel the 50, you see, I don't know if you can focus better here, my bolus. I go, I I push laterally because I want a thick bolus. I inject 0.6. That is what nowadays I always inject. You see that I maintain, I said, my lady, that she will have a bump, a lump here. And so she is ready. Okay, it is visible, I guess, also for you if you focalize here. I push here because also Sebastian told us that the filler comes back through the cannula, and so, entry point. And so I push here to avoid that the filler comes back, and I do my second entry point. Here you have, you see the line of ligaments, temporal, orbital, zygomatic, mandibular, lateral face, mid face. I inject the lateral face, and so from here I will inject the lateral part. And so I do entry point, again, thank you, and immediately I do some light subcision because I want to create some space here. You see, here it is not normally painful, and I inject again 0.6 here, and from this point I will inject also the temples. Okay, and now we prepare my second vial, please. The lateral to the line of ligaments, you see the zygomatic part, and many times I come back now, and I turn, and I inject over the, you see exactly here, I inject my remaining part. Perfecto. Second vial. Thank you. Now we do the temples here. I re-enter from the same entry point, and I am in the, you see, I arrive just to the temporal crest that you can see in Sebastian Cotofana's wonderful dissection. I always like, and I do a linear retrograde technique. You see, with a very nearby, okay, okay, I am here, exactly. Don't make one here and one there, but remain very perfecto. I go up. Very good. Normally there are, you can proceed very easily. And I am here now, from the air down. Okay. And I injected 0.6. So until now, I injected 0.6 in bolus here, 0.6 in the temples here, 0.6 here in the... Now I divide this, I make my entry point, please. And from this side, I am usual to do this part, thank you. And, okay. And I do the jawline. Again, you see, I am very in the subcutaneous tissue. And I would like ask 1 second Sebastian, if he is in has the possibility, if also he agrees to inject superficially, or instead he prefers to inject deeply. Sebastian, are you there?
Of course, Alessio, and as usual, I always agree with you, because here in this area where you're currently now, the superficial plane is the preferred plane. And I'm demonstrating exactly what you're doing. I'm following you one after the other step that you're conducting. And I'm also showing to the audience that the superficial plane is a safer plane, because if we go into a deeper plane, then we find the respective artery and the respective vein, which are in a deeper plane. And this is why going deep, you are close to the respective vessels. You can see here the artery, you can see here the vein, you can also see the marginal mandibular branch overlying those respective structures. But as Alessio showed you very, very beautifully, we want to stay superficially, because all of these structures are deep and we're staying superficial in a more superficial plane. Alessio, with this, back to you.
Thank you. So it's good to inject here in the superficial plane, and I follow this. I go upstairs again, sorry, up, and I am here. It is very important, the place. Follow me a second. The artery goes up this way, and this turn, and you have here along the hairline, you have the superficial temporal frontal artery. Here, just up of the ear, divides quite in 70%. I did many studies with the echography, and I saw that these two arteries create an epsilon, and here you have the parietal temporal artery. So you have to go in the middle. This is perfect. I did 100 cases, as I told you. You can find my publication in January, and it is so easy to avoid the artery, because I saw some alopecias that are done or because there was an encapsulation of the artery, but it is difficult, or a pushing up of the hair. So now I am here and I start injecting. You see, I put a finger because the filler comes back along the artery. Sebastian, also on this you have a very good points. How do we have to inject? Quickly or slowly to avoid this reflux of the filler along the cannula?
Alessio, and I think this is a very important point, and I heard that many times, and you also mentioned this, because a good injector is a slow injector. We learned this from various injectors, including Arthur Swift, including also from you. We know this, the slower the better. But Alessio, while you inject this, let me show quickly to the audience this V that you just demonstrated to us. I would like to bring this again to the attention, because it is important to understand the vasculature of the temple. In my dissection right now, you can see I'm reflecting the skin, and now I'm also reflecting the superficial temporal fascia. And as I'm reflecting the superficial temporal fascia, you can see that here I had to cut the superficial temporal artery, because otherwise I would have not been able to reflect. It's coming from down here. And if I'm reflecting the superficial temporal fascia, you can see the flap, and inside the flap there is the artery. So the artery is not on top, it's not below, it's inside the superficial temporal fascia. And the branch that you can see here so beautifully traveling anterior, that's the anterior branch. And here you can see the posterior branch going upwards. And if we switch the top camera view, you can also see that I had to cut the posterior branch, which is going here. So I had to cut that posterior branch because it was also connected to that respective artery. If you go to the side view, we can see again the respective connection. So I had to transect this, and if we're reflecting now, we can see exactly the V so beautifully that Alessio is referring. You can see exactly the V here, because that V is located in this area here. And exactly in this view, this is where Alessio is injecting. And Alessio, it is true, applying product into the temple, into the right plane is crucial, but understanding that it has to be the subdermal plane allows the injector to inject away from the artery in a different plane. And I think this is really important to understand. The artery is deep, we're injecting more superficial. And with this, back to you, Alessio.
Oh, thank you. Always when I hear you, I convince myself that what I am doing is nice and it is true. Because you have this faculty to convince me, and I already injected 0.6 bolus here, the classical domino. 0.6 here, you see, please, if you can focus a bit on temples, you see how much uniform it is. I don't injected 1, 2, 3 boluses that many times disappear in 15-20 days. I injected the same quantity, but very uniform, without waves. Now I am injecting laterally. You see here where I am, exactly on the line of ligaments. From here back, and I inject a little bit, then lower. I already did my subcision that I told you here. Okay, a little bit more here, but just a little bit to smooth this part. That is good. And remember, always so important to inject the part behind, and go there is so easy because you see, in this way, I am in the right plane, I turn and I go in this part. You see, I am here, subcutaneous tissue, and I inject. I have a cannula 70 now. So the cannula 70, I arrive until here without any problem. And I inject not so much in each channel, but also this is so important. You see how easily I go. And also this part, do you agree, again, I am so lucky to have you here, Sebastian. Do you agree with this retrograde injection also in the lateral part, or you think it's better to remain only in this medial part?
Alessio, I think it's absolutely doable, and it's sometimes also necessary to inject in the lateral part. The reason giving is because you apply, and we work together on this one, on the aesthetic principles, which is lateral face first. So this is why going into the lateral face allows to precondition what happens in the medial face. In addition to this, I also would like to mention to the audience that the injection direction is exactly perpendicular to the pathway of the arteries. So if the arteries is traveling like towards the forehead as it does here, the injection direction is going perpendicular. And in this way, the contact area is very little because we're injecting perpendicular to this. And now you might say, but wait, you're injecting here going straight upwards. Yes, but you're injecting between the V and you're also in a different plane. So this is why, Alessio, I could not agree more with you with the process of going from the medial aspect into the lateral aspect.
Thank you for convincing me again. I am in the last part. I injected my 2 vials. You see here this part. I am down here, not too down, but to inject this part in a uniform way. I am on this side. Again, I inject. You see, I am in the subcutaneous tissue over the parotid gland, over the facial artery, over the masseter muscle. Now I turn, again, I try to, and I am finishing, and I go down here. You see, I don't know if you are able to see these veins. I go below these veins, and I inject. I don't know, dear guys, dear colleagues, if you had the chance to try these new syringes by Filmed. Incredible. Our syringes, always we get something more. I was so happy of the older syringes. But the syringes, these are really incredible. My microphone fall down. Please, I have here my good colleague that will follow me. Thank you. And I finish. Okay. And I wanted to see, you see, maintain this little point. This is the 5th syringe, because I wanted to see the result. And please, oh, I have my beautiful lady, smile, wonderful. You see, I don't know if you remember the nasolabial folds, much less. I want to wash my lady. Thank you, please help me. You will see Dr. Borriello also immediately after me. So I present you my colleague. And you see the jawline. You see the jawline. A little bit here more. You see? A little bit here. This is perfect, wonderful, I like. This is wonderful. I don't touch anymore. So a little bit here. I ask, please, the entry point, the needle, and I go to end my session. I redo a little entry point here. Perfect. Thank you. Thank you. Thank you. Perfect. And I go here millimetrically. You see, I am here. Very good. This last 0.2, 0.3 ml is so fundamental to get the final good result. Thank you, Carlo. Okay, we see back. You see, much better. Smile, good. Okay, I think that I have, sorry if I am a buffalo, but to remove these lines is so difficult. I don't know if we have any question or if we have the questions later. I get back to Professor Luo. I have finished and I thank you very much.
Okay, thank you, Alessio and Cotofona. It's perfect. You give us a very, very impressive concept and the demonstration is great. Thank you. With the understanding of original protocol, let's welcome Dr. Carlo to perform Domino protocol with focus on deep piriform fossa. Dr. Carlo, please. Dr. Carlo?
Can you hear me?
Yes.
Okay.
Thank you.
Hello, everyone. Thanks to having me here. It's an honor for me to stay here today. Thanks to Alessio, Professor Redelli. Wouldn't be easy to be better, to inject better. But today, with this new patient, we focus always on Domino, but we focus in a new area. When we need some projection in the middle cheek, we can use an injection deep on bone in the deep piriform space. But we start, my injection, as you can see in the slide, my injection will be, can I have the slide, please? The slide? Okay, my injection will be focused on 3 areas. The anterior temporal area, the temporolateral cheek fat, so an injection superficial, and the deep piriform fossa. We try to respect with this the philosophy behind Domino, because Domino was born for, as Sebastian told before, for injecting in an area and co-influence the other area. So we have to imagine that when we inject in this area, the result will be, can you close near, the result will be this. So the co-influence means that I inject in the temporal fossa and this part of the zygomatic area goes up. Another one was when I inject in this part, in the superficial, in temporolateral cheek fat, the co-influence in the tissue will be this, and the patient will have this result. When we inject in the piriform fossa deep, the co-influence create this movement. So the final result will be this, a lifting of the tissue without injecting in a usual part. So now we can start. I start with temporal fossa. The point of my injection is the swift point. So starting from the temporal fusion line, I inject 1 centimeter up, 1 centimeter up, thank you Alessio, 1 centimeter over. This is my area of the injection. When I inject the filler, can I have the volume with needle, please? Okay. When I inject in this area, the gel can go in this direction, but here we have the temporal fusion line. In this direction, but here we have the orbicularis retained ligament. So the gel will go in this direction or this direction. We want the gel in this direction. So I put a finger here and I inject directly on bone. This is I am on bone, directly on bone. Then now I give the aspiration. Aspiration is very important. And then I put my finger here and start injecting. As Sebastian told before, slowly injection, gentle and slowly. If we ask patient if sta sentendo qualcosa, patient doesn't feel anything, any pain. Very slowly injection. Sebastian, what do you think about it?
You're doing absolutely fabulous the way how you currently perform the respective injection, because, as I said before, and Alessio also mentioned this, always a slow injection. Important also to note is that you perform pre-injection aspiration. Of course, there are various reasons why it can be negative. We then call it false negative. And amongst those various reasons why it can be negative, one of them is you're not in the artery. The other reason is you did not wait long enough, or it's a wrong product-needle combination, or you don't have enough negative pressure in the plunger. There are various reasons for the negative aspiration. However, and I always say this during my presentations, it's like playing in the lottery. You can always complain that other people are winning, but you don't win in the lottery. And then if you ask, do you play in the lottery? I say, no, because I don't win anyway. But this is the point. If you don't play, you don't win. The same thing with aspiration. If you don't conduct the aspiration, there is no chance that you see blood in a needle hub. So I think that's a very important aspect, and I'm very, very happy that you demonstrate the pre-injection procedure here for this webinar and live on camera. And I'm really looking forward when you're gonna switch to the midface, because then I will show the anatomy in greater detail for all of the layers of the midface when you move to the other
Avviciniamo
side.
un po' lo schermo, allontana un po', leader far.
And now back to you.
Have a look to the tail of eyebrow, and this tissue goes up, no bleeding. So when I stop my injection, I've only to put my finger here and massage, gently massage, to allow the gel to go down. If I have injected 1.2 ml, 1 syringe. So if I see usually the injection in 0.6, 0.5, but in this case I need to feel for lifting. So usually I inject from 0.6 to 1.2, in this case 1.2. As you can see, there is isn't a painful injection. It's very easy. It's a huge important, the aspiration, huge important, but the treatment is very fast and effective. Now I inject with Universal the temporolateral cheek fat. I need a pencil, please. I have here, okay? Just a moment. Now I start from here, and I distribute my gel in a fun technique in this direction. The only thing you know, and Sebastian, I ask your opinion, is that the temporal lateral cheek compartment that was described by Rodic and Pesa in 2007 is one of the compartments in the face that lose its volume. So usually in the philosophy of filler, it could be when we have a losing of volume, we have to restore this volume. So where we lose volume, we put filler. Every time we create a new volume in an area where is not necessary, we will modify the shape of the face. The philosophy by Domino is lifting the tissue, to repositioning the tissue in the same position, using a filler in a smart way, using a gel in a smart way. That's it, why we inject posterior the linal ligament, and why we don't prefer to inject medially. In few minutes, I will show you also the piriform, but the philosophy is exactly the same. I start with my injection, entry point in the gonion. I use 1 syringe of Art Filler Universal. I'm superficial, very superficial. I'm using on the syringe a 22 gauge 50 millimeter cannula, and I inject with a fanning technique, very slowly. Asciutto va bene. When I have some resistance, I rotate the cannula because I pass through some fibrous septum, and I inject very slowly in a fun technique. Slow injection. Art Filler Universal is perfect for this area. Sometimes I can inject also volume when the losing of volume is more, but don't remember that we are injecting superficial, so we have to hide the gel. And in a patient like this, with a skin so thin, if we inject art filler volume, probably we can see the line of gel, and we don't want to see the line of gel. The injection is finished. gentle massage. Very gentle. Have a look to the patient. Look the lifting effect in this side. Can you appreciate the result or not in this side instead of the other one? Perché la faccia la paziente storta? Okay, look at this. Okay? So we're injecting one syringe of heart filler universal, one syringe of heart filler volume. And now it's time for deep piriform space. Let's speak about deep piriform space. Deep piriform space is a space, is the wrist of space that Christopher Surek in this article proposed to rename in deep piriform space for the continuity with the premaxillary space and the prezygomatic space. The aging, during the aging, we have a modification in a bone, the maxillary bone recess. And this creates a sliding laterally of a deep medial cheek fat. And this is the reason for the losing of medial cheek projection. Since the beginning, the description of deep piriform space, many authors postulated and suggested that filling this space create a pillar, create a fulcrum lifting that allows tissue to go laterally. And this, if we think about the philosophy of Domino, this respects the philosophy of Domino. The injection will be a deep injection on bone. There is a huge variability of the facial artery, of the angular artery in this area, but it's also true that it's not common to find the artery on bone. The only thing we have to pay attention is to perform the aspiration. If you will say red, don't inject, remove, press, wait 1 minute, and then retry the injection. I will show you. The injection, abbassa un po' il mento, is in this area very deep. Can I, disinfettante? Okay. Okay. No, it's universal, please.
So before you start injecting, can I quickly walk the audience through the anatomy of that respective region? Would that be okay?
Of course.
Wonderful. So before we position the injection, and as you said absolutely correctly, into the deep piriform space, which was previously referred to Bruno Ristov, let me walk you through the anatomy quickly so we understand where the respective vessels are traveling. To do so, we're going to look into the top view camera, and what's happening here is I dissected the skin of this respective region. So we're going to reflect the skin upwards, as you can see here. And as I'm reflecting the skin upwards, and you can see this also in the lateral view, it is important to note that this fat, as it was said previously very correctly, this fat is highly mobile. And this fat, as it is mobile, normally it's located up here in this upper region here. But during the process of aging and clockwise rotation of the facial skeleton and of the retrusion of the maxilla, this fat loses its foundation. And then from this position, it's moving downwards. This is why providing volume here will help to reposition that respective fat layer. In a superficial fatty plane, we can see some very minor vessels. And if we then reflect the superficial fatty layer, as I do this now here, and will stay in the side view, then you can appreciate here, for instance, the zygomaticus major muscle. You can see this muscle here, and under this muscle you can find the transverse facial septum. In a top view, you can see that respective component. You can see how deep it suddenly is in the midface. The reason why here is, this is here a more mature patient, and the respective bone is retruded. As we reflect the superficial fatty layer, we can expose another muscle. The muscle that you can appreciate here is called levator labii superioris aleque nasi. That is this respective muscle that you can see here. And look what we find on top of the muscle. On top of the muscle, we find directly here the branches of the facial artery. So this artery here, and in most of the cases, it travels superficially. And this is a very important feature to understand, because if we're reflecting now levator labii superioris aleque nasi, and I'm turning the head slightly towards you so you can appreciate this better, I'm reflecting the muscle. You can see this here. And as I'm reflecting the muscle, you can see the infraorbital neurovascular bundle, the nerve and the artery. You can see that the nerve leaves the bone and starts to become more superficial.
Okay.
And this leaves exactly this space here free. This space that you can see here, this space here in contact with the bone in this area, this is called the deep piriform space. That is this space here. And look where the artery is. The artery is superficial. You can see exactly that respective difference. The space is deep down here on the bone, the nerve is more superficial, the artery is more superficial, and this is why the product placement here into this region is the preferred positioning of the product. Why? Because artery is superficial and we're injecting deep into this area. And again, don't be confused about all of these branches here. This is all sensory nerve. This is all branches of the infraorbital nerve. And for reference here, if we're putting back the levator labii superioris aleque nasi, the rest of space is closed, as well as with the respective superficial fatty layer, which relies on the volume of that respective space. And with this, it also provides skin surface projection for the overlying skin in this respective area. And I hope with this you can understand how the positioning of a deep product in contact with the bone can elevate the soft tissues, can reposition the soft tissues, and can give you more volume in the upper cheeks. And this is exactly what we're going to see now with the respective safety considerations. And with this, back to you.
Thanks, Sebastian. It's always a pleasure to hear from you. Every time I hear your explanation, this section, it's a pleasure. Okay. Look my finger. Put the finger here. Target the bone. Direct. No, just a moment. Direct on bone. I'm on bone. Okay? Now, aspiration. The rule says 5 seconds. 7 seconds. And now slowly injection. Very slowly injection. I'm injecting 0.7. Slowly. No bleeding. We have only to push. This creates an elevation of nasionabial fold. And if you can see the patient, spostiamo un po' la camera. Move the camera. Okay? Have a look at the difference between the two half. Very fast, very easy. But I want to see very safe. Because we are working for the safety of the patient. It's a safe injection. It's a really safe injection. And that's it, the result of Domino. We're injecting 2.76 ml of gel, and look how the face of patient is completely changed. But now, for make an happy patient, we have to do also the other side. So, please, restart with temple. I always start from the top. So, the same. Disinfecting the area. Un bato flasciutto, per favore. Grazie, Alessio. One up, one over. I feel the temporal fusion line with my finger. I target the bone. Aspiration. Okay? And then, Alessio, put my finger here. Slowly injection. Very slowly. Nice and slow, gentle injection. After this injection with 1.2 ml of gel, patient can could feel some little pain when bite, but it's normal because here there is the temporalis muscle on the top. So sometimes happen. I usually speak with patient and explain her that it doesn't matter. It doesn't need to take some medication, but sometimes if they are concerned about, we can use a paracetamol, not more. Remove the needle, no bleeding, absolutely no bleeding, okay? And now push the finger and massage, gently massage. The gel will fill the fossa. And that's it. Now, universal in temporolateral cheek fat. Put the cannula superficial. There is some septum. Okay. Very gently start the injection. From this point, I can go also on the mandibular line, but in this patient, I don't need to do it. Sebastian, what do you think about it? Is a safety plane in your idea?
Absolutely, absolutely. The plane in which you're currently in now, this is a safer plane because this is the subdermal plane. We know that in this plane, there are no major vessels included. So that means the majority of the vessels, they are all located a little bit deeper. And I would like to show you this here in this dissection. And I mimicked this before when you did it in the previous patient. But if I'm reflecting the superficial fatty layer, and you can see that here, that it shows very nicely that there are only very few subdermal vessels. The ones, very few that are there, are the ones that you also know and you see during surgery is the one branch of the transverse facial artery that travels through the zygomatic ligament, that's this one. But otherwise, there are no major vessels in the entire subdermal plane. You can see that here. And even if you go down, all the way down into the neck, into the respective layers that overlie the platysma, there is no superficial vessel located, and the same thing with the temple, as you can see here. However, we need to consider that as we move into the forehead, and you can see this here, then from the temple, the vessels start to become more superficial in the forehead. And we know that the majority of the vessels in the forehead are located superficially. And here you can see beautifully the transition of the superficial temporal artery from deep anterior to the tragus, interfacial in the temple, and then subdermal into the forehead. So that's one of the vessels that changes the plane. But otherwise, I 100% agree with you. The subdermal plane is a safer plane. And in this way, it allows a very nice product distribution, as you performed very beautifully with the cannula, as you moved and advanced into that respective plane to homogeneously distribute and refill the respective fat compartments. And on this note, I also would like to mention, you made a very important comment about the fat compartments. The fat compartments in itself, you can imagine them like pillows or even like the tire of a car. When there is sufficient volume inside that compartment, there is stability. For instance, in a car, you need to have the proper tire pressure to able to be driving, right? The same thing with the pillow, you need a certain volume. But the volume here is to give you structure, to give you stability, and to maintain the original position. Think about it. Maintaining the original position with volume, because as we lose volume over time, and you mentioned this so beautifully, as we lose volume over time, we lose structure, we lose stability, and then we have the descent of the respective fat compartments. But this is just my view from the research side. But you can see this in a clinical practice on a daily basis, right? You see that.
Absolutely agree with you. I continued with the last area, the piriform. I changed the needle. Every time you touch the bone, every time we touch the bone with a needle, let's change it, because it's easier to inject. So target the bone, my finger directly on bone, tuck, I'm on bone, I am on bone, okay? Aspiration. We go. Slowly injection. Very slowly injection. The patient feels creak is the bubble inside the syringe after aspiration. Slowly injection. That's it. No bleeding, very clean injection. A little massage. Gentle massage. We can see the face of the patient. Completely lifted, easy, effective. This is the magic behind Domino. So I think that now, Sebastian, have you something to do, something to say about this area?
So I think what you mentioned very correctly is also the Domino philosophy. Of course, when we talk about the Domino philosophy, we talk about lateral face first, upper region first, but the other concept is also deep regions first. And this is also a part of facial biomechanics and how they all act together. And if you think about the philosophy of the Domino, is you target one area, but you have an effect on another area. This is kind of like how the Domino name came. And I do think, especially injecting into the piriform fossa, is an adjustment for the individual needs of each patient, because every patient is different, and we cannot expect that we have the same treatment strategy with every patient. I mean, this does not work. It was done in the past, but now with understanding of anatomy and science, we moved away from this and we individualize our treatments. So we conduct a respective Domino treatment, as you did very nicely, with the temple, with the lateral face, and then we assess the patient and we realize that there is a recessed maxilla. And in this way, we need to adjust for the patient needs, and then we're addressing that patient need, because this is to be adaptable to addressing and understanding the needs of the patient. And if you think about really kind of like Domino means you treat one area, affects another area. But think about, we injected into the piriform fossa, but the effect was a little bit higher because, as you said very correctly, you provided support for the adjacent reason. So I think this is kind of like all in line with the Domino strategy when I see it from the research and from the anatomical perspective.
Thank you, Sebastian. Thank you. And now the patient is probably happy. Now we give her a mirror just for seeing the result. And I moved the stage. I leave the stage to Professor Lu and see you after for the question and answer. Thank you.
Thank you so much, Carlo and Dr. Codofona. It's a simple and effective injection technical. Thank you. Now I'm inviting my Chinese colleague, Dr. Xia Wei, to do Domino adaptation profile. Welcome, Dr. Xia Wei.
Hello,
Welcome.
Professor Luo. Hello, Professor Luo. Thanks for the introduction. my dear colleagues. I'm Dr. Xia Wei from Xi'an. And here, it is my turn to talk about the Domino Asian version. So first, let's talk about what's the same with the classic Domino. Of course, we share the same philosophy by Apple repositioning of the soft tissue. We move the lower tissue upward to create a positive collateral lifting effect. So the philosophy is the same. And also, we all like to put our injection site lateral and upper to the ligament line. You know, we have to identify the ligament line of the face and then put our injection upper and lateral so we can pull the soft tissue upward, give us a lifting vector. We all avoid to put too much volume, too much filler in the medial side of the face to avoid overfitting syndrome or make us make unnatural expression. And also at the same way, all like the V-shaped face, the V-shaped face. Therefore, we put the vast majority of fillers on the upper face and less in the mid face and less in the lower face. So in the Asian version for the upper face, the site 1 and site 2 are quite similar with the classic Domino. And what's the difference? The difference probably is on the mid and the lower face. Because in our Asian, we always usually have wider mid face. We have fully developed cheekbone. So in our culture, the excessive cheekbone always give us an impression of bitter aesthetic. We don't like that appearance. Therefore, we discussed this with our Chinese team and Professor Luo, of course, and we make some adjustment. We divide the injection of the malar and or the zygomatic eminence. We avoid to inject here and move the injection site, divide it and move the injection site medial and lateral of the elements. Therefore, we can also provide the upper lifting effect of the midface and avoid excessive augmentation of the cheekbone. And for the lower face, we Asians usually have a square face. We have strong bony and musculature to support our lower face. So the descending rate of the soft tissue of the lateral lower face is relatively slow, which gives us the reason not to, it's not necessary for us to inject for the mandibular angle and the ramus. Therefore, we made some modification from the classic Domino into our Chinese version. When we made the injection for the lower face, site 5 and site 6, mainly for the lifting vector. Site 5 is from the mandibular ligament to the masseter cutaneous ligament. That's for the lifting for the corner of the mouth. And also we have the site 6 from the lateral of the chin to the mandibular angle. That's for lifting the mandible to give us better V shape. So this is our modification made for the Asian version of the Domino. And here, after my introduction of the Asian version of the domino, I'd like to hear from Professor Luo and Professor Kotofana about our idea of the Chinese version of the Asian version, actually.
So thank you very much for explaining and adjusting that respective domino treatment. And I hope this shows again to the audience that the domino effect and the domino treatment strategy is adjustable and respects the individual patient's needs. Domino is a general concept, but it has to be adjusted to every patient. And I think you made a wonderful presentation when it comes to understanding the differences between the Caucasians and also the Asian faces. And I would like to emphasize these again based on what you said, because it's so crucial to understand these concepts. If we go to the side view of the camera angle, I would like to show you the side view, and actually it's an oblique view of the donor that I'm having here. In Asian faces, this area here, this malar eminence and the zygomatic arch is more pronounced. It makes sense that you do not want to add more volume here on the lateral aspect, but you want to move from this lateral aspect more into the medial aspect. And here in the medial aspect, it's important because here it's therefore a little bit flatter. And this is why, again, we still apply upper face first, lateral face first, but we are adjusting the domino because the domino respects the patient's needs. So from this area, we're moving slightly more here into this area where we have a little bit of volume deficiency as opposed to, and all of this is of course in relationship, more volume here on the lateral aspect. And then you mentioned something very important about the anatomy in the lower face. And in the lower face, you also mentioned very correctly that there is a very strong lower face volume. But what gives us volume in the lower face? For this, let's reflect layer by layer to expose that respective region. I'm reflecting the skin. I'm reflecting now the platysma and the SMAS as in the next plane. And now this exposes what you can appreciate here. This exposes the masseter muscle. On top of the masseter muscle, we have this nerve, which is called marginal mandibular branch of the facial nerve, which I'm moving towards the lateral side. And also we can expose and understand the parotid duct and the respective transverse facial artery, which I'm also reflecting laterally. And as you know, as I'm reflecting the nerve backwards, you can see how they travel into the respective parotid gland, which is here. And as I'm reflecting the parotid gland here more posteriorly, we can expose the entire extent of the masseter muscle. You can see the masseter muscle, it's a fairly wide, fairly substantial muscle, and this muscle is attached to the mandibular angle. The volume of this muscle determines how much tension we have in the lower face. This is why the incidence of jolts and soft tissue descent moving downwards when the volume of the masseter muscle is being reduced is increasing, because we have less pull towards the lateral aspect because we have less volume with the respective masseter muscle. And if we understand that the Asian patient has not the needs to increase that volume, as opposed to the Caucasians. Caucasians, they do need volume here, as opposed to Asians, they don't. It also makes sense why the respective treatment algorithm is moving from the posterior lateral aspect here in the lower face to the anterior aspect, because all of these aspects are adjustable and the domino effect respects the patient's needs. And now, before I let you start injecting, I would like to show to the audience one of the important ligaments in the midface, which you will address later on. For this, we're going to go to the side camera, and I will move towards the side here, as you can appreciate this view now. And I'm again reflecting here the skin, as you can see this area here. And when I'm elevating now the orbicularis oculi muscle, which you can see here, and the malar fat pad. As I'm reflecting those structures, suddenly you see this space here. This space here is the SOOF, as you can see here, and the lower boundary of the SOOF. This one is formed by the zygomatico-cutaneous ligament. And the upper margin here is formed by the orbicularis retaining ligament. And between those ligaments here, there you have a space, and that respective space is referred to as the SOOF. And here in the top view, you can see that now here we have a boundary here, zygomatico-cutaneous, and the other boundary here is orbicularis retaining. And between those, we have the SOOF, which can be very nicely addressed to reposition and especially give volume to the anterior midface, as you can see here. Now I'm putting back the skin, and I hope now you understand how the anatomy, if the anatomy is understood, that all of my experts here do this, and you at home also understand the anatomy, how the anatomy can be utilized to individualize the treatment and to still apply the domino concept to every patient for maximizing the aesthetic outcome. And with this, we're going back, and I'm looking forward to seeing the treatment.
Okay, fantastic.
Okay. Thank
Now we
you,
have
Dr.
better understanding of
Xiaowei.
the-
Your
Okay.
demonstration showed us how you adjust the protocol to adapt Asian patient. I totally agree with you. Please just show us your injection technique. Thank you.
All right. Okay. I will start from the right side. I have a model here. So let's take a look of our model. I have a beautiful model. She's in her 30s, actually 36 years old. And she's complaining about the drooping of her eyebrow, corner of the eye, slight nasolabial fold, and slight to moderate the Marriott line. So we're gonna use the Domino Asian version for her to correct the ptosis of the tissue and to give elevation and the lifting effect of her face. So we start from the right side of the face. As mentioned before, for the upper, mid, and lower face, we all have 2 injection sites. For the upper face, I will inject the site 1, the lateral temple. The site 2 is the swift point, as we mentioned before. So 1 and 2 of the temple give us the lifting vector. Hopefully, after the injection, we can see uplifting of the eyebrow and the eyelid. So let's start with the site 1. Okay, relax. I'm gonna use 23G needle cannula for site 1. Okay, so first, I use the 21 gauge needle for the skin opening. All right. All right. And so I will go directly on the subdermal plane. Quite superficial. You can see when I put the cannula in, the tissue around her eye, the eye and eyebrow is uplifting. So here, see slowly in the right plane. So if we are in the right plane, it's actually a little bit hard to go inside. All right, so I have the 5 centimeter cannula. Now the cannula is all in. I'm going to put 0.6 It's actually half of the syringe inside here. And I will give the filler in a retrograde fashion, slowly, slowly, slowly. Retrograde. Okay, not fanning, not bolus, just a linear thread. Okay. So here, 0.6. Okay. So that's for the side 1. Okay, nice, clean, no bleeding. And for the side 2, it's a swift point. I'm using the 1 up, 1 over technique. I repeat here, 1 up is 1 centimeter up from the temple fusion line and 1 centimeter up from the lateral orbital ring. So here is our side 2. I will use the 27 gauge needle for the injection, gunshot injection. So here, I put my needle in all the way down and touch the bone and stay. And aspirate, stay for 3 seconds. And then slowly, slowly, slowly inject. And open your mouth, please. 张一下嘴. I will ask my model to open her mouth a little bit to relax the temporalis muscle. Okay. So I will put 0.6. So half the syringe here. Okay. So little bit massage. All right. So after the injection of the upper face, we can see the lifting of the eyebrow and the corner of the eye of the treated side. Okay, then we move to the mid face. Okay, need a little pressure here. For the mid face, as we mentioned before, we avoid to inject the eminence. Therefore, we choose the side 3 on back of it on the lateral side. Lateral and on the inferior border of the zygomatic arch, lateral to the zygomaticus major muscle. So that will give us the upward lifting effect of the nasolabial fold. So here we'll give the injection of set 3. Okay, please. Instead of 1 big bolus, I will divide my injection into 3 tiny bolus, 0.1 milliliter for each bolus, each side. I will put 3 tiny bolus. So here, by uplifting lower part aspect of the zygomaticus. Okay. Aspirate and then 0.1. Okay, nice. Another one. Touch the bone. Aspirate 0.1. Okay. The third one. Touch the bone. Aspirate then 0.1. Nice. All right. Instead of the big bolus, the 3 tiny bolus can give us the smoother contour of the cheekbone and will not overemphasize the lateral side of the face.
Can I quickly add something to your explanation?
Sure, no problem.
Thank you very much. It is important to note that on the zygomatic arch, it was in the past thought that there is no fat compartment crossing from the temple into the midface. However, recent research has shown that from the temple, there are some communications downwards towards the zygomatic region. So that means when we inject for the zygomatic arch, it's important to note that, as you see very beautifully, sometimes we grab the tissues and then we inject here in contact with the bone. This is very important to stabilize the product and also to keep the product in that respective location. The other component which is very important is it is a needle injection. It's a perpendicular needle injection, as you can see here. And that means that the product will migrate along the created canal and will give you a very nice projection and support of this lateral aspect. And this is different as opposed to cannula injection, which would give you a different aesthetic outcome. So here, during this live demonstration, you were able to see that you use the needle and the product distribution to your advantage to give you support in the lateral face.
Exactly. So the lateral face is by anchoring the soft tissue can give us the lifting. Then we move to the medial mid-cheek. So for this injection site, I first I draw a line from the lateral cancers to the oral commissure, and then another line from the alopecia to the tragus. With the intersection of those two lines is our injection site. It's in the superior part of the zygomaticus cutaneous ligament and down to the bone, and the target tissue is the lateral suit, as Dr. Cordovana mentioned before, Professor Cordovana. So here is our injection site. 4, please remove this. And I'm going to use needle for this injection. So another 0.3 for this syringe. So here, that injection site, you insert the needle, touch the bone, and then hold still and aspirate, then slowly inject 0.3 milliliter. That gives us the another lifting effect of the nasolabial fold. And also for the mouth corner, you can see after the injection of the midface, can we see the both sides? The treated and untreated area. Okay, nice. Nicely, you can see here. Okay. Nice. All right, so let's move to the lower face.
Just quickly before you go to the lower face, there's another important aspect that I want to mention to you is that because the orbicularis oculi, which you can see here, is continuous with the midfacial mass. And even the midfacial mass is becoming very thin and almost non-existent when it reaches the nasolabial fold. The superficial fat that is located here contributes to the formation of the nasolabial fold, because it has to be noted that it's normal to have a nasolabial fold. Everybody has a nasolabial fold, and it's absolutely normal. Even babies have a nasolabial fold. And the reason is because the muscles of facial expression, they connect to the skin. I think you can see this area here. I'm reflecting the skin. You can see how the muscles connect here. And because the muscles connect, this fat has a natural boundary. it cannot move further. It has a natural boundary. So during the process of aging, this fat moves towards the nasolabial fold, and this fat accumulates here because there's a natural boundary. By injecting here, how we just saw it very beautifully, we apply tension and traction and reposition the entire soft tissue flap back upwards towards the midface. This reduces the nasolabial fold effect, as you can see beautifully, and gives you a very nice projection of this respective area. And everything has to do with the underlying anatomy and how all of the respective layers are interconnected with each other. So I'm really sorry for this interruption. Please feel free to continue with the lower face treatment.
Oh, it's okay. I'm always glad to hear your explanation. It helps us to further understand the whole philosophy. Thank you, Dr. Kotofana. So here we move to the lower face. For the lower face, we mainly make the lifting vector for the lower face instead of just give volume to the mandibular angle. We not inject here, we inject here. So how to find the entry point? So I'm marking the marionette line and lateral to that line. And the vector is from the mandibular ligament to the masseter cutaneous ligament, as I labeled here, from here to here. So that will give us the lifting of the mouth corner. So here I will use a 23 gauge cannula for the fanning technique to give 0.3 milliliter of the product. So here, let's start. Okay, let's remove the label. Okay. Okay, I use the 21 gauge pilot needle. All right. Okay, so here I need the cannula, 23 cannula. I put the cannula in and along the subdermal plane towards the masseter cutaneous ligament here. So here we are. And then by retrograde fanning fashion, I will put the product in here. Okay, so here we are, 0.3 ml. Massage to make the product evenly distribute underneath the skin. All right. Then our side 6. The side 6 is 1 centimeter away from the chin point. And still, as we mentioned before, I will still use the cannula. So pilot needle in and the cannula and the left. So 0.3 ml. Still subdermal plane along the inferior border of the mandible to smooth the jawline. Retrograde fashion, linear thread. Okay, maybe more here. So great, linear, nice. So altogether, I put 2 syringes of the film med volume. 1 syringe for the upper face, half syringe for the mid face, and half syringe for the lower face. Now I finished my injection for the right side of the face. So let's take a look at our model before and after. So let's move the face. We can see the lifting effect of the treated side. not much volume, but we can still see the effect of the eyebrow lifting, corner of the eye lifting, the improve of the nasolabial fold, the improve of her jawline. So here is it.
Okay,
Sure.
thanks to Dr. Xia Wei.
Mm.
It's wonderful. Due to the time is limited, I would like to invite Dr. Xia doing the injection to the other side, and we can start the QA. After the
Okay.
QA, and you can show us your final result. That's
Okay.
impressive. Thank you.
Thank
Okay.
you. Thank you, Dr. Thank you,
Oh,
Professor
you're
Luo.
welcome. Thank you. So we have some QA from the audience. First question is for Dr. Alicio. Alicio, is you are here? Dr. Alicio. Okay, thank you. So first question is for you. And your injection bonus into the temples, in the hair, and the fun-feeling subcutaneous or subdermis tissue outside the hairline. How is your patients think about it? Is it palpable outside the hairline, the hairline? You think your patient is palpable? It's a little bit superficial. Yes. How do your patients think about that? From this area, yes, not inside the high hairline and outside the hairline. Do you think your patient will touchable your feeling, your derma, under the derma, subcutaneous derma? It's the first question. You can't hear me? I can't hear you. Sorry? No voice?
No, 1, 2, 3.
Okay, perfect. Thank you.
Okay.
So, Professor Alicio, the question is...
I heard very well your question.
Okay.
And the answer is that my patients have light problems in the air. For the bolus in the air, I take her hand and I let them touch. And I say them, this is normal. You can't do in a bald man. Maybe if you see my wonderful colleague, Carlo, maybe in him is not so good. But in a beautiful lady with hair, there are totally no problems. And no one patient told me, well, what it is, because I say them and I explain them very well before, not after. What you say before is science. What you say after is excuse me. Instead, in the part where you don't have hair, you must be very uniform. This is the trick. If you are very uniform, you don't see anything. And so the patient will not say you totally nothing. So I totally don't have any problem.
So how many volume normally you inject in this area?
Normally, I arrived after many, I started with 1 ml in the air and 1 ml in the temple. But nowadays, I arrived to 0.6 in the air in bolus and 0.6 in the temples from the temporal crest exactly to the zygomatic bone. So 1 vial.
Okay, thank you, perfect. So next question is to Dr. Carroll. You inject 1.2 filler into the temple area on the bone. According to some study, of course, some study also from the Cotofona, inject into deeper layer may cause the effect of volumization only. How do you think about that?
I injected the temples. I've been injecting the temples for more than 10 years. And usually the injection of 1.2 ml represent the 60% of my injections. Till now, I've never had any problem. So
You think it's just so for lifting or for volumization? For temple
in
hollowing?
my idea is for lifting. It depends on the patient. I use the technique for lifting, not for volumizing. But you can consider that 1.2 ml create also a volume, so it's a volumizing technique. Sometimes, if I use also the technique of Professor Redaelli with cannula, and I inject less on the deep plane 0.6 and 0.6 superficial. But in this case, the temporal area has completely lose its volume, so it needs a lot of gel to fill the area. Usually is for lifting, but we can use also for volumizing. It depends on the amount of your product.
Can I add a little thing? And for this, I would like to have also the comfort of Sebastian, that is a master in this. Of course, I inject maybe the same quantity, but in two different points, because I am more superficial. Instead, Carlo is deeper, and so injects one point with more product and uses maybe more material. This is related to some biomechanics, Sebastian, and it is true to inject more deeply and less superficially, or you think differently?
Okay, thank you, Alessio and Dr. Carlo. And Dr. Cotofona, could you show us the deep temple fascia from the cadaver? You can show us the deep fascia? It's how it's tough and how it's hard. Can you show us with the cadaver for deep temple fascia? Okay, so we can continue our question. So next
You are on
question
mute,
is to
Sebastian.
Professor Potocona. How do you distinguish temple hollowing deviation and temple lifting? What is different and what can we do? Those two indications.
You are on mute, Sebastian. We
Yeah,
can't,
we move to the Sebastian.
we can't hear you.
Oh, yes, sorry. Dr. Cotofona, can you hear me? Can you hear me?
We
I
don't
can't
hear you.
Sorry, I can't hear you. I just hearing from the Dr. Alessio. I can't hearing responsible from the Dr. Cotofona.
So in the meantime, can
Hello?
I ask you, Luo, that I know that you are an incredible anatomist. So what is your opinion on this? Is it normal that we use more product deeply and less product superficially from your experience?
Yes, I really quite agree with your opinion. I think if a deep injection, we just give a little bit more volumization and just a little bit projection. This projection can induce lifting, but it's not much efficiently. It's not lifting enough. I think it's could be most probably useful for volumization or for projection for your temple, but not for lifting
The
for
camera's
your
off.
nasolabial fold.
The camera's black.
Okay, Dr. Cotofona is coming.
Yes, I
Okay.
am back here, and
Now, Can you hear me?
Yes, yes. Can you hear me
Yes.
as well?
The next question is for you. So
I know. I heard all of the questions before, and I would like to emphasize on the points also that Alessio mentioned before. The important aspect here when we consider is, and Alessio mentioned something very important, distributing the product in different layers, and then per layer we have less product. This approach is called multi-layer technique because we apply per layer less product, and because in a temple we have multiple layers, which I will show you in a bit, it makes sense to apply less product per layer because this reduces the risk of adverse events that can happen when we inject a lot of product per layer. However, it's also important to note that when we're injecting deep into the temple, and there was a publication by a colleague from Dubai, his name is Rami Haidar, he investigated and found out that the deeper we inject into the temple, the less the volume effect spreads to other areas. So in other words, with more superficial techniques, we'll have a wider field of effect, and with the deeper techniques, we have a more narrow field of effect. However, we know, and Carlo showed us beautifully, with injecting deep into the temple, we can have an effect on the eyebrow. And this is resulting also because of the deep temporal fascia, which you were able to see previously. So let me walk you through these respective layers in a bit. So when you reflect the skin, you also reflect the superficial temporal fascia, which you can see here. And then you can identify this very, very thick layer here. This very thick layer is called deep temporal fascia. And this layer, as you can see here, is continuous with the periosteum. I removed the temporalis muscle under and below the deep temporal fascia, and you can see that all of this here now is continuous with periosteum. So periosteum and then deep temporal fascia, which is a very strong fascia in the temple. And as we're reflecting the deep temporal fascia, then we can identify the temporalis muscle, which you can see here beautifully. But there's a very important aspect to consider, because from the temple, there is a connection into the midface, which is the buccal fat pad of Bishar. You can see that connection here. And this is where we have an access from the temple down into the midface. And this all is overlying the temporal fossa, which you can see here beautifully. And now we have to understand that the further downwards we move in the temple, the deeper the temporal fossa is. And that means the more volume is needed to volumize and to project and to reposition. And therefore, there are a couple of techniques that volumize this area, which will then give a tensioning effect to the deep temporal fascia and also to the superficial temporal fascia. And now, this is a very important feature to consider, that the superficial temporal fascia has a connection to orbicularis oculi, and from the orbicularis oculi, we have a very intimate connection to the eyebrow. So by volumizing the temple, we can achieve a repositioning and a lifting effect of the eyebrow, which Carlo showed us very beautifully during his demonstration. And if we put all of these layers together, and we understand also what the multi-layer technique is, what Alessio mentioned, then it all comes together in one concept where we're injecting according to the layers, we have different effects, and all of them have something to do with the underlying anatomy, right?
Thank you so much. That's perfect. Yeah, thank you. So now, Dr. Xiaowei, first please show us your model.
Okay, sure. So here is our beautiful model after injection of the both sides. So do we remember what she like before the injection? Now, is she after the injection? Without giving too much volume in the medial face, we just provide lifting the eyebrow, lifting the eye, lifting the midface and lifting the jawline. So that is the purpose of the domino effect. And I think by the modified Asian version, we mission accomplished.
Okay, that's great. Now the last question for you.
Okay.
Now we have one question for Dr. Xiaowei. Do you prefer needle or cannula when you injection in the lateral side or zygomatic area? How do you think of the difference?
Okay, for the injection of the lateral zygomatic arch, either to select the cannula or the needle, it really depends. First, depend on what the purpose of the injection. As we know, in the injection, it's problem solving. So we need to see the problem. So if the problem is to improve the nasolabial fold, so we have to see the nasolabial fold is here. The most economic way to elevate the tissue is perpendicular to that line. So with this direction, we have to make the lifting vector. So if the nasolabial fold is quite long and to the lower part of the face, maybe on that part, we need to use the cannula for fanning technique for the lifting vector. And if the nasolabial fold is just beside the nose and on the upper part, on that direction, we can make the vector just along the zygomatic arch. So for that direction, most direct way to give the lifting effect is to put the needle on top of the bone and anchoring the soft tissue and give quite solid lifting. So really depends.
Okay, thanks a lot. Okay, thank you for all your performed work and my dear colleague. Very nice. I think time is up and we have to close the event today. That's all of today, and thank you all again for your hard work and participation. Please scan the QR code on the screen and give us your feedback. Thank you so much. Bye-bye. Bye-bye, Dr. Alicio, Dr. Kylo, Dr. Cotofona, and Dr. Xiaowei. Thanks a lot. It's really great event. And of course, thank you a lot for the PhilMed team. They give us much more support. And thank you. Thank you again. Good morning, good afternoon, good evening for all of us. Thank you.
Bye. Thank you. Bye.
Bye-bye.
Okay, bye-bye.
Thank
Cotofona, see you next 3 weeks. Yeah.
Yes, see you soon.
See you soon. Yeah. Hope to see you in China. So, okay.